systemic periodic diuretic.
What?
Because we don't want a DVT. All right, there's that triad again. Probably going to see it. What's a DVT? So, development of a blood clot.
I just opened her cat video and it decided to send me.
Well, at least she was honest, right? Okay. How many are on Facebook right now?
I was for a second.
Okay. Don't Facebook. All right, so what's a DVT? It's a blood clot in a deep vein. Typically, like we had, remember your deep veins, your popliteal, your femoral, these type of things. So you now have a clot that's formed, and that's a problem. This actually can be a life and death deal. Typically, if the clot is above the knee, it has a higher percentage chance of going to the lung and causing a pulmonary embolism. If it's below the knee, you're probably pretty safe. So you'll find that treatment modalities change with location of the DVT. If it's above the knee or if it's below the knee. So something a little interesting thing to know. All right, so age and gender. 100 times higher in hospital than in the community. Patients with venous thrombosis. Third die within 30 days. 20% have a PE. So again, that has to do with location of the clot. Okay. I don't think you really want to spout out those percentages to your patients, but they need to be aware of the risks when we're dealing with the clot, when we find out where it is. So it's all about location. So hospitalization within the past 2 months, major surgery within the last 3 months. Board exam question right there. That's your vignette. Your vignette is going to be a patient that is seeing you for calf tenderness and swelling and had a fracture repair done 3 months ago, that kind of thing. That's what you're going to see. They're probably going to be a smoker. They're probably going to be overweight. You know, it's just this. I can almost guarantee you a DVT question will be on your boards, and it'll probably be on your test for this section. DVTs is probably what you're going to see the most, and this is where we have to kind of really have good clinicians. I mean, we really have to kind of tune in and really. You can't miss this one. Okay. This one's kind of a big deal. So know your risk factors, because I guarantee it's going to be in the vignette. So provoked, unprovoked, or idiopathic. Remember, idiopathic, we have no idea why you have this DVT, but you have this DVT. You have none of the risk factors, you have none of the, you're not the typical patient, and all of a sudden you have a blood clot. So why? Well, we have to do some digging to try to figure out why. That's really the big thing. But typically it's going to be provoked from a major trauma or an illness or something like that. That's where you're going to see it. So, did y'all have to buy a tape measure? No. No? Okay. Well, if you do family practice, internal medicine, and that stuff, you're going to see tape measures out. And that's not because we're seamstress or that we do any kind of measuring of anything other than we measure calf circumference. So measuring calf circumference is part of your charting, it's part of your physical exam. You must do this on all patients that complain of this. Okay? If you don't, you failed. Because this is kind of a big deal. So where are you going to measure? 10 centimeters below the tibial tuberosity. Where's the tibial tuberosity? Right below your knee. There's a little flat spot on the tibia. How much is 10 centimeters?
How much the tape measure says it is?
Let's go. Use your tape measure. Why do you have to measure how far down?
So that way you can accurately be on both sides.
Exactly.
Consistent.
Exactly. Because you're going to measure both angles, and you want to measure them from the exact same location. All right, that's real important. So you use your tape measure, you measure down 10 centimeters, and you wrap the leg. Okay. So if there's a difference of 3 centimeters between the extremities, DVT is #1 on the list. for differential. Now, do some people's legs swell unevenly? Yeah, but not typically 3 centimeters. You may see 1 centimeter difference, but not 3. So you're also going to have erythema. It's going to be red. It's going to be tender. Everyone heard of Omen sign? Do y'all use Bates for your clinical assessment? Do they use Bates? A textbook? No. Okay. So Omen sign, there's all kinds of YouTube videos on it. I would highly recommend you look at that if you don't know what Omen sign is. That one is one we do for everybody we suspect of a DVT. Basically what that is you have them flex the foot, and with flexion of the foot, if it produces calf tenderness, because essentially you're having them contract their gastrocs. If they're having calf tenderness, that's another reason for high index of suspicion for DVT. All right, so here's a cartoon illustration. Normal blood flow, then you have this clot that has formed. Notice that it's underneath a valve. So you've got some stasis that has happened from a valve that's caused this clot. This is why you have valvular damage from a DVT as well. All right, so, and then what happens is the dreaded blood piece of the clot breaks off. Well, it's fine as long as it travels the pathway of the big highways, but then when it gets lodged down in the smaller little veins and it gets stuck, and it's actually bigger than the circumference of the valve, then we have a problem. So this is typically how they look. It looks blurry. Yeah, it's kind of blurry. Sorry. When you blow them up, they get blurry and blurry. But you see the redness, you see the swelling. You can definitely see that there's a difference. Okay? So this is a clear difference between pedal edema and unilateral leg swelling. Don't miss this. Don't automatically go, oh, that's just pedal edema. Yeah, it's congestive heart failure. No, not if it's just in one leg. Typically, you're going to see pedal edema in both legs. Okay? So unilateral leg swelling, redness, redness, DVT, number 1 on the list. I mean, is it a cellulitis? It could be, and that needs to be on your list. But the first thing you're going to rule out is DVT. That's what matters. You can deal with the cellulitis later, but it's the DVT that matters. You don't want to miss that one. All right, there's a well scoring system. There's a lot of EMRs out there, Epic, Meditech. I don't know if you've had any exposure to any of these before. But they have these scoring systems in your documentation, and it's all risk stratification. Pancreatitis has a scoring system. CHF has a scoring system. There's a lot of different conditions that have scoring systems, and DVT is a big one. Now, all patients that get admitted to the hospital, you must address DVT risk. Because, if you remember from that slide, prolonged hospitalization is a risk stratification for DVT. So if you're admitting a patient for hypertension, you have to address DVT prophylaxis. And whether that is compression stockings, or if you're going to anticoagulate them, or there's different options that you can choose, but you're going to find part of your admission orders that you're going to write is for addressing DVT status. So that's how much of a big deal this one is. Because to develop a DVT in the hospital is your fault. Okay? Because you didn't address it, you missed it. All right? So that's how much of a big deal it is, and your hospital administrators will be calling you. Okay? So know your risk stratification, make sure you deal with it. So what are we going to order? The first one on there, D-dimer. We know that one, right? How accurate is a D-dimer?
Not very.
It tells you if there is or isn't a clot.
So, close.
Not
D-dimer, a negative D-dimer is good, but a positive D-dimer doesn't mean anything. Okay, So the purpose of the D-dimer is, if you are in rural America or rural Oklahoma and you're in a little critical access hospital, and that's pretty much your only option is a D-dimer, and your ultrasound is only available during the day and they're not available at night, and it's 2 o'clock in the morning, and all you have is a positive D-dimer, you're going to be sending them for an ultrasound that may be negative. So how do you explain that to a patient? I think you might have a clot, I'm not sure, so we have to do this next test, but I can't do it right now, we have to wait. I have to send you. So I'm going to put you in an ambulance and I'm going to transfer you to tertiary hospital, and they're going to do this ultrasound and it's going to be normal. And they're going to find out it's cellulitis, and they just got a big ambulance bill and everything else for, they're going to come back to you and go, I don't want to pay this. Anyways, that's a whole other. D-dimer. CBC, CMP, PTINR, PTT. I think all these things make sense, right? CBC, what are we looking for in the CBC? Looking for platelet count. What else? Signs of infection, which would be? So high white cells, what about on the differential? Have we done hematology much?
Yes.
Okay. So leukocytes, you're looking for high leukocytes, left shift, that kind of thing. Would make you suspicious for cellulitis. Is it possible to have elevated white cells and have a DVT? Absolutely. So CBC doesn't mean anything. Again, it's just another, it just helps to paint that picture. Okay, so it's an important part of this. So yeah, there's the D-dimer. Probability of DVT is low. So what do we send them for? Venous Doppler ultrasound. And this is not a gallbladder ultrasound where they just, it's a different kind of ultrasound that they do, and they actually give you your index, your flow, that kind of thing. You may get these reports back and you're going to have to know how to read them, how to interpret the data, and then decide what you're going to do. Okay? So if on your clinical rotations you ever have a chance to sneak away to the radiology department and actually see a Doppler ultrasound being done, I would highly recommend you do that. Okay? At least see 1 or 2 of them so you understand the process and how they get their numbers and how they get their readings and that kind of stuff. Talk to the radiologist. If there's one there, man, pick their brain about this stuff, because I'm telling you, I don't care what you go into, you're going to deal with DVTs. So you're going to need to know this.
Are D-dimers ever used, I remember we talked about them a lot in heme, but are they ever used inpatient? They always said it was outpatient.
Yeah, so it's mostly ER settings for your initial. It's not something they would monitor over time, like maybe infectious markers and stuff like that. It's just usually that initial D-dimer that they'll run. Now, if I had a pneumonia and you treated me for my pneumonia and I'm better, and that was last week, I could have a positive D-dimer still. So that's why it's not an absolute, but it's just another tool in the toolbox.
So if someone comes to the ER, the fastest thing to do for now is a D-dimer until you get a Doppler?
Yeah, yeah, you're going to order a D-dimer if you're suspecting any kind of blood clot. It's just part of it, but it's not. If you're transferring that patient and you talk to the accepting physician and you say I'm transferring because they have an elevated D-dimer, they're going to go, okay, what else is there? I mean, that's not the diagnosis at that point.
Okay.
So if I have a patient that comes in with shortness of breath, and the last week I find out they had surgery on their ankle, that kind of thing, what am I worried about then? PE. Am I going to order a D-dimer? Yeah. But what else am I going to order? Good, good. You guys are on. Yeah. So VQ scan is okay. The gold standard now is a CT chest with contrast. Remember, anything we're dealing with the vessels, we got to order contrast. So if they have creatinine, or if they're 600 pounds and your CT scanner only holds 400 pounds, you got to think about other options. So VQ scan would be the next option. Okay. But good. So what are we going to do for treatment? Well, again, it has to deal with the location, right? If it's below the knee, we're probably just going to anticoagulate and follow up. If it's above the knee, we might go in and suck it out. We might go get it. go after it. We can put in some filters. We'll talk about this Vena Cava filter. You guys ever seen this before? Okay. We got some images on it. I'll show you. We put one of those in for sure because we don't want that to get to the lung, right? So the theory is that Vena Cava filter is going to catch the clot before it hits the lung. All right, but we got to do heparin. Typically, though, we go Lovenox with bridge therapy. There are other options out there now. What are some other anticoagulants that are out there that don't need monitoring, like Coumadin? Yeah. That's right. Xarelto, yes. And you'll probably find that that's what they're gonna, that's what your group's gonna probably prescribe. Is it wrong to prescribe aspirin? No, you just gotta get them on some kind of anticoagulant, okay? Again, it just depends on where you are. Now, if you are prescribing Coumadin, then you have to monitor INRs, right?
Yes.
INR stands for? You guys are, man, you just spot on. I have to say I'm pretty impressed for 5 months in. So INRs, 2 to 3. In a patient that doesn't take anticoagulants, we would freak out and go, oh my God, what's wrong? But in a patient that is coagulated on Coumadin, this is the target you're looking for. Sometimes we'll even see it above 3. What if it's 8? Yeah. What have you been eating? Most of the time you'll find it's diet related. Because there's diet, there's green leafy vegetables, spinach, that kind of stuff. If they're not eating the same kind of stuff, then they're taking too much and you have to tell them to cut back. So then there's peaks and troughs with Coumadin that you have to monitor. And you will be the one calling them, saying, okay, skip your Coumadin for the next couple of days, then take it. So you'll be providing patient education for Coumadin therapy. Why do we still prescribe Coumadin when we have all these other options? Money. So if I'm 75 and I'm living on Social Security and I have to choose between my medications or eating, you follow what I'm saying? I'm not going to spend $100 on Eliquis when I can get Coumadin for next to nothing. And most of the time Medicare will cover it. So again, Coumadin is very frustrating, but you will probably deal with, if you're doing family or internal, you're going to manage Coumadin for sure. Compression stockings for sure, but catheter-directed thrombolysis. So we're going to go in there and we're going to suck that clot out. Depending on where it is, you got to know exactly where it is. So you've got to do a CT contrasted study and locate where what clot is, and then determine how you're going to get to it. Typically, you're going to, your inguinal clots, femoral clots, those are going to be easier to get to. So it depends on the location. All right, so here's that green filter. Can y'all see it in the x-ray? So you're going to order all kinds of imaging studies. You're going to have a patient with constipation. I always use constipation because it seems like it's the majority of abdominal pain that come in your ER constipated. But here's the filter right here. This patient's also had lumbar surgery. So that is a lumbar fusion surgery, if you want to know what that is. So those are screws and rods that are in the back there's bone growth. It's a solid fusion, if you want to know. There's solid, so between the transverse processes, they put the bone out here to grow, and that's how they perform a fusion. All right.
What's wrong with their hips? They're all cockeyed.
Might just be a little bit of the scoliosis. It might be a little rotated. This might be the view of it. Although you have some arthritis and some narrowing here in your symphysis pubis, you see that? So you've got some arthritis, you've got some osteophytes starting to form here on the side. So this is an older patient, which is not surprising because the risk stratification is typically in older patients. You see this. But someone who's had more than one blood clot, if they don't have a filter, something's wrong. And you need to find out, why did you not have a filter put in? Because they need to have a filter deployed.
So we had an forgetting. When do you take it out?
It's like 2 months.
Is it,
I don't know that answer, to be honest with you.
I think it's 3, but is it 2?
It's
2 to 3? Okay.
I want to say longer,
Okay.
but I don't know. I don't know. All right, last section on the home stretch for my lecture. Sorry, that's bad. Okay, so where do we see these venous ulcers? So there's arterial ulcers and there's venous ulcers. Okay? Typically, we see the venous ulcers in the lower 1/3 of the leg. Have to know the differences between the arterial and venous. Lower 1/3 of the leg, pretibial area, anterior to the medial malleolus. Okay. Did you get my good side? Or? No, you were taking a screenshot. Okay. All right. So, how does it look? I think we've all seen these, and these guys. I got some wonderful pictures to show you here. But reddish brown pigmentation, again, is keratin deposits, dry, itchy, scaly skin, dermatitis, dilated veins. They may be warm. You should have normal pulses. There's your differentiating between arterial and venous. So, will you be able to palpate them? No, but if you get a Doppler out and you can Doppler a pulse, and you know, okay, you've got good leg pulses. Okay, so you should have normal pulses, dorsal pedis pulses. It's flat, irregularly shaped. It's not painful. Remember I said, oftentimes they can't really feel it. And you'll be, but no dead necrotic tissue, no gangrenous tissue. When I say dead, I mean black. It's going to look nasty and pussy and a lot of fibrous tissue and stuff, but not gangrenous like black, like the raisin in the sock. All right, so there's one. So this is an example of how you chart. If you're a wound clinic PA and you're seeing patients, they're gonna take images of the ulcer each time with each visit, and it's going to be measured, and you're going to document this in your note, okay? Because this is going to show you progression, how much you debrided, how much cellulitis there is. So this is a typical follow-up documentation. I guess that other picture didn't go through. Okay. All right, now arterial. So where is it located? Well, typically it's on the tips of their toes. It's the raisin in the sock. Okay. Over phalangeal heads. So again, distinct differences between a venous and an arterial ulcer. Location plays a role here. No hair, hair loss. Hair requires blood flow in order to work. Shiny skin. Thickened toenails. That's usually a fungal infection. What you see is that the toenails get real thick. I just don't like feet. Y'all know that already. I'm not a feet person. But it's part of the job. Maybe cool to the touch. Absent pulses. Diminished pulses. We have a problem. Okay. And characteristics, typically black necrotic tissue. You've got a full thickness wound. The wound edges are smooth and regular. Pale, no hair growth. So they're all diabetic, I can tell you. They're all going to be diabetic. And if they're not, they got other issues, but majority of patients you're going to have are diabetic, and they smoke. Oh, my picture didn't work. Oh, there we go. So that's a classic arterial ulcer. You see the black necrotic tissue? You should be able to see that from across the room. Yep, okay, that looks... That's the toe. Is that typically where you see these, right? That's the location. Remember location for arterial. So yeah, tip of the toe. So again, this is another documented, this is how you document your chart. And electronic health records, this will just pull into your chart. You'll see the pictures just kind of show up. It's really kind of nice how they do that. Made it. I still have 30 minutes.
We still have lunch.
Great.
After that.
What questions? biggest thing of all this, you're definitely gonna see venous insufficiency, you're definitely gonna see DVTs. You're gonna treat them, you're gonna manage them, you're gonna prescribe antibiotics, you're gonna prescribe blood thinners for them. You have to, you know, they're all, you become a problem solver, and that's where you shine. And so you really need to know your resources. You need to know who your wound people are, who your wound PA is, or who your wound clinic is if you're doing family. So know how to refer a patient. Make sure you go the extra mile and get it all set up for them. If it's home health, know how to get a hold of home health. Know who you're using. You're going to have to know their insurance. So some of that stuff that, there's a lot of providers that would turf that to their nurse. Don't do that. Make sure that it's done and you know it's done right. Go the extra mile on these patients because they fall through the cracks a lot. This is a situation that falls through the cracks a lot, and patients get missed. And if this is your mother or your dad, you don't want that to be the person that gets fallen through the cracks. So the take home here would be those two. Those are the two biggest things that you're going to see. All right. Okay. Thank you, guys.
You could take 5.
Yeah.